All right. Okay. Welcome, everybody. It's really nice to see you all. This is the September System of Care Learning Collaborative. Really nice to see you all. If we haven't met, my name's Christy Hudson. I use she, her pronouns. I am Transformation Manager with the System of Care Advisory Council. And I see a few new faces and names today. So if you are joining us for the first time, welcome. We're glad to have you. This is a monthly convening hosted by the System of Care Advisory Council and Oregon Health Authority for anyone who is working in, impacted by, or interested in the system of care. So we cover a variety of different topics every month. And the focus of this month's Learning Collaborative is we're going to do a little bit of a deep dive into some of the barriers that were recently reported by local systems of care. So, local systems of care are required by their CCO contract to report on the barriers that they have learned about from youth, from families, from providers, from system partners. They summarize those barriers. They share them with OHA. And then the System of Care Advisory Council somewhat recently has started analyzing those barrier reports for themes. We've summarized what we heard in the 6-month report. So this is the reports reporting on January through June of this year. A summary document is attached to this calendar appointment. If you didn't get it, we will send it out with the recording of this particular collaborative. And today we're going to do a little bit of a deep dive on just a few of some of the more commonly reported barriers. So that's what's in store for today. We're going to use some breakout rooms, so hopefully get people interacting and really problem solving together on some of these challenges. If you all want to say hello and introduce yourself in the chat, that would be great. And while you were doing that, I am going to pull up a quick slide deck. Okay. All right. And Christiana or Anna, I've got like a billion things going on my screen, so please help me out if there's something in the chat that I'm missing. Um, okay, so here we are. We're going to discuss and share strategies to resolve commonly identified barriers. So, really going to be working together to share things that maybe you've tried in your region or ideas you have. We also have some subject matter experts from a variety of state agencies that are going to be helping us and providing resources, policy clarification. So, hope you brought your questions. We've got some real smart people joining us today. Thank you so much for being here. Um, so there were a lot of barriers. I'm not going to go into the report, consistent themes. We're still seeing most barriers related to accessing care and services of all sorts. Transportation was another common barrier. Workforce challenges was another common barrier. There were a lot of other barriers that we couldn't necessarily categorize within the provided categories, but lots of important things. Um, if you have questions or you want to see additional detail on any of the barriers, I'm happy to share that report with you. Um, but today we're just going to focus in on 4 barriers. So accessing assessments, treatment and supports for things like autism, ADHD, and fetal alcohol syndrome, care coordination, and childcare. And I just to kind of give you a sense of the types of things that people were explaining and describing, I've got some quotes that I pulled from the barrier report. So these are direct copy paste of situations as they were described by our local systems of care. So, accessing assessments. Examples included testing for autism, ADHD is not available for an 18-year-old youth who is still in high school. Diagnostic services are not available in Malheur County, but it could be any county, for youth above the age of 6 with suspected autism. There's a long wait list to get into and receive a diagnosis. The youth received care, but the process took too long or it was more difficult than it should have been. The wait lists for assessments are extremely long for folks with OHP, Oregon Health Plan, Medicaid. So if that sounds like something you are hearing at your tables or something you are struggling with and you want to go problem solve and talk about that, there will be a breakout room for you to discuss that. The second barrier, support, treatment, therapies for intellectual and developmental disabilities, specifically autism, ADHD, and fetal alcohol syndrome. So a couple examples here. In rural areas, there is a scarcity of local services for families with children who experience autism. Many of the appropriately trained providers can only be found in population centers such as Salem or Portland, and navigating public transportation with a child with complex needs can be overwhelming. The few local providers who do serve this population often have long wait times. Some online options are available for assessment and ABA, applied behavior analysis. However, not all families choose to engage with services in that medium, meaning online. Several of my clients present with persistent and significant behavioral challenges that affect functioning at both home and school. The primary diagnosis is fetal alcohol syndrome. While they are receiving services through CLCM, apology, I do not know this acronym. Somebody can hopefully help me out. Anybody? CLCM?
I don't know that one.
Okay. Presumably a service provider of some sort.
There's a note in the chat.
Oh, community living case management. Thank you, Tammy. So while they are receiving services through community living case management, including access to personal support workers when available, and accommodations such as weighted vests and room alarms, their needs go beyond these supports. What would be most beneficial are developmental disability specific skill building groups, parent education, and individualized skills training. There are ABA organizations in Eugene that will provide treatment, but fetal alcohol syndrome diagnosis does not qualify. Okay. Next room will be about care coordination. Here are a couple of examples. Community partner agencies have expressed concerns about gaps in care coordination following acute care interventions, such as when youth are screened for mental health concerns in a hospital setting. System of care partners working in mental health services are particularly concerned about the lack of timely and appropriate follow-up care for these youth. This barrier also identified limited community education regarding levels of care and alternatives to emergency room services. The transition process creates a gap in care. During this transition period, youth need to find a new provider to assist them with medication management and other treatment needs. These transition periods are bridge periods, which may require a bridge provider to support the youth until they can get established in a new level of care with a new agency or program, which commonly takes many months. The bridges in the current system are failing, and youth are not receiving timely medication management or treatment. Okay. And then the last room is going to be about child care, and specifically child care for children with complex needs. During a system of care re-engagement meeting, stakeholders and community members identified access to child care as the primary barrier facing youth and families, particularly those with children who have intellectual and developmental disabilities. We currently have no child care providers that accept employment-related daycare funding and limited options beyond 3 Head Start locations. These Head Start programs serve only families meeting specific eligibility requirements, leaving significant gaps for other families. The county lacks specialized child care providers equipped to serve children and youth with IDD, creating additional barriers for families with disabilities. And the second example here, while our community has robust home visiting programs for caregivers of children with disabilities, it can be difficult for those caregivers to find traditional childcare options that have providers who are trained to support children with complex behavioral and medical needs. which can create barriers to attending appointments, finding work, and providing care to other children in the home. Okay. I'm sure you all have a lot more to say about those four areas, which is great because now we are going to give you an opportunity to go into breakout rooms. You get to pick one of your choice. Sorry if that's a hard decision. Let's just do one room. These are just some example questions for you to think about, but you'll have a facilitator, you'll have a policy expert, somebody from a state agency will be there as well. This is really just hopefully you'll have some open and generative conversation that is solution oriented. But here are some questions you might think about. What actions have you taken? So if your local system of care has been working on this thing, what kinds of things have you done or what could you do to resolve the barrier? In absence of additional resources, okay, trying to recognize that things are a little dicey out there and we are in a constricting environment. So in the absence of like funding, how could you make it better? What are some things that we could do today or next month? What partners have you engaged or could you engage? What are other system partners doing to address this barrier? So who else have you talked to? What networks and solutions have you found that way? How could you ensure a sustainable solution, right? This is about system problem solving, not individual problem solving. So how can you find a solution that fixes it for everybody? And what supports would you need from SOCAC, from other state agencies? Um, how can we be a support? Okay. Any questions? Is it Mady? You have, is that a question for?
Yes, that was a question for my friends from Delk who are on the call. And I think we were going to join the childcare group. We were just
Yes,
chatting
that would be great.
offline. And if
Wonderful.
that works for you, that's what we'll do. Thank you so much.
Yes, yes. Okay, here are a few resources. There are probably more that hopefully we can kind of contribute to during our time together this afternoon, and we can add to this. Um, and I can try and drop some of these into the chat if it's helpful. I think probably most of you know about these things, but if not, some resources here might be some starting places. Um, but yeah, with that, let's get into the breakout rooms. So if you want to go talk about assessments, you'll be joined by Jesse Egan from Oregon Health Authority. If you want to talk about care coordination, I think our Jennifer and I see Jen and Carol Files are both here from OHA's Medicaid division, policy experts on OHA's CCO care coordination rules will be there to support you. Childcare for neurodivergent children or children with complex needs. You'll be joined by colleagues from DELC, the Department of Early Learning and Care. And treatment and services for IDD, things like autism, ADHD, fetal alcohol. Your room will be joined by Chelsea Holcomb from Oregon Health Authority. Okay. Now is the tough part where you have to make a decision about what room you're going to go into. How about we'll plan on like 20 to 25 minutes? Does that sound good? I might do a little time check and see how folks are doing. If you need more time, we can certainly do that. And then when we come back together at about quarter of, it would be great to have some sharing out. So when you go into your rooms, if you can identify somebody who can kind of take notes and help summarize what the conversation was so we can all learn from that. I think myself, Anna, Selby, and Christiana, do you all mind splitting up and helping to kind of facilitate some of that? Okay. All right, here you go, folks.
Christy, do you care which room each of us facilitators hops into?
I don't care. No. So do you want to shout at you? Is there a room of interest in particular, Anna, you want to go to?
I'll go to care coordination, I guess.
Then I can go into the assessment one. I was torn between care
Oh,
coordination and assessment, so
But
There
that's
we
great,
go.
Selby, because of the barrier y'all just submitted. It's so related. That's great. And Christiana, that
Whichever one
leaves
you need me in.
your choice. Treatment and services for IDD?
Sure, that
And then
works.
and I'll go to childcare.
Sounds great.
Okay. I'll hang back. Just Hillary, are you asking a question? You're on mute.
You've got Chelsea in that room, so maybe we pick the rooms where there aren't already our team members. But
I think I'm going to act as a facilitator instead of a participant or a subject.
oh,
Yeah, different rules. Roles, sorry.
yeah. Okay, you take Chelsea. Is there somewhere you want me, Christy?
Your choice. And if you're having trouble finding a room, let me know. I can be over. Sometimes the breakout room is a little hidden.
I am not seeing the breakout room
Okay.
options just yet.
Is going
So
to-
Oh,
they
here.
might not pop up for you. You might have to click the join breakout room
Thank
sign
you.
at the
Maybe it's-
bottom. That's
Yep,
what I
thank
had to
you.
do.
Thanks.
All right, here we go.
Hillary, where do you want to go?
I'm actually your co-host. If you didn't realize that I've been letting people in,
Oh,
I can
great.
choose my
Thank
own my own adventure here. I've been quietly just putting people into places.
Karen, do you have a preference?
I'll do the treatment and services for IDD.
All right. Now where do I get to
Okay.
go?
It looks like Chris and Selby are the ones in the with the quietest room with Jessie.
I know. Where to go? Where to go? I'm gonna go to
And
care coordination. Okay. Are you gonna, or did you want to go? I can hang back, I guess.
I was going to go to I was going to go to the care coordination one.
All right. Why don't you go? I'll hang back.
Thank you.
Okay. Enjoy.
And I will keep an eye on anyone joining the meeting.
Thank you.
If it lets me join. Oh, there we go.
All right. Welcome back. I always take it as a really good sign when like no one comes right back when the room's closed. So I both apologize for like what was probably like an abrupt end, and I think that means you were all having some really robust conversation. So, thanks for still hanging in. Would love to hear some sharing out of what you all discussed. If there were some great problem solving strategies that you identified, would love to know what you all talked about. So how about we start with um Jesse? Do you want to get us started? It was on developmental assessment. Jesse, and was Christiana with you or Hillary?
They were not, but I did have Selby and Chris and Michelle were
Yes. Great.
together.
Yeah.
And I promised that I would do my best to summarize as long as they would chime in if I missed anything. So I don't know that we got to all the questions, but we did have a pretty robust conversation. We talked a little bit about what resources folks did have, and it sounds like everyone, because Selby came over in theory as part of the planning committee, but then ended up being a member of the conversation as well because, HealthShare does have their own resources and also struggles in this area as well. So we talked a little bit about sort of, the there are resources, there are assessments that are getting done. It sounds like in some ways it's easier for younger kids. There's sort of 0 to 5 or 0 to 6 have some resources. We talked about why only 0 to 5 or 0 to 6. There seems to be sort of a magic cutoff. A little unclear why there's sort of a magic like at age 6, other than some folks have a policy. Maybe there's a measure that sort of changes at that place. There's a competency or a tool where folks feel like they don't feel as competent to make those diagnoses after that age. But it seems as if once folks get a little older than that, teens and adults are having a harder time getting diagnoses. And we talked a lot about what people have actually tried. And it really feels like asking just around, Chris was saying, they've got folks where it's like they're asking, does anybody know anybody? We will contract with anyone. Does anybody have any resources? And, there are folks who work in hospitals and going across over into Idaho. They've been able to find some people, but, there's a lot of workforce issues. So we talked about ways to really kind of best use the current workforce. If there's ways that we can use the school psychologists, like the psychologists that we have now, some of the ways that we can kind of train up some of the pediatricians. There's a couple of different cohorts that have happened with some pilot projects that are interesting, looking at ways that pediatricians can diagnose autism, and also looking at ways that we can train the psychologists that we have to maybe do what they can do to put things in their reports to make sure that if there's a question about a developmental disability, that they can get what is needed in their reports to make sure that the eligibility is there, so that there's not another assessment needed and we don't have families that are kind of getting the runaround where, oh, well, you got an assessment, but it's not the right assessment. And the other thing that we talked about is there have been some successes with folks that have kind of had jobs of doing community outreach and kind of working with families where a lot of families are kind of told that the DD system can be all things to all people and, sort of do everything for everybody, which really is not true. And so sometimes it's really helpful to kind of get out there and work with families on what can the DD system do and what can they not do, and make sure that if the DD system is not going to be the support for a family, that it actually is best just to not pursue the DD system, because it can be even more frustrating to go through all of these things and go, oh, I was told that I need a neuropsych exam. And so they're pursuing all of these things and maybe even paying out of pocket for more and more tests and having a hard time finding them. And if you don't actually need that, or it's not going to be the solution for your family, doing all of these things and then being told, no, you don't actually need that at the end of the day, is even more frustrating and more disheartening. So having some folks that can sort of be a navigator and telling a family at the beginning of this process, here's what DD does and what they don't do, is actually a relatively cheap way of helping parents find the path that they need. So I think that's the summary. Selby or Chris or Michelle, anything that I missed?
I'm going to try to throw in one thing really quick.
Excellent. Please do.
Oh, sorry, Chris, did I cut you off?
Nope, you're good.
Okay. So some of you know, so I'm Tri-County System of Care, so Clackamas, Washington, Multnomah counties. My name is Selby. We actually have a barrier related to this topic that we're bringing to the SOCAC State Council next month. But there's one idea we didn't put in our submission because we were really wrestling with it. But I'm still really curious about this idea. And given the attendance here today, which includes some leadership people, I'm going to toss it out there for you to think about. So the idea we were wrestling with is that schools can evaluate students for things like autism, ADHD, and even some intellectual disabilities. They cannot diagnose, right? The diagnosis is different and it's based on medical criteria. But in terms of expanding access, we were really kind of curious and wrestled around with this idea of what if the school evaluations somehow became an accepted form of assessment that could be used to access other services, whether that's in DD or, you know, anyway, or other services. But so we really wrestled with that idea because the school evaluation is different than a diagnosis. And if you open access, you need workforce. And again, so we didn't end up putting it in our submission, but I actually still remain really curious about the school evaluations and how, if the policies were changed around what those could be used for, like how that might increase access or some kind of middle road of access, so to speak. Like maybe they don't need full DD engagement, but maybe the family could have some kind of intermediary engagement between what a school could offer and what DD offers. So it's a bigger issue, but anyway, just wanted to put that out there. So all of your great minds can also wrestle with it.
That's great,
I'm
Selby.
in
Thank
complete,
you.
I'm in complete agreement, Selby. That's what I was going to pop in and say, hey, let's talk about this.
Mhm. Yeah, Chelsea, you had your hand up for a second? Did you?
I was just putting a heart, but that I was just going to say that also came up in our group. Like we're trying to narrow in what is that policy? Where is that policy on what area where that lives? Is it the education policy? Is it a medical, like who's made the decision that once you get this diagnosis of X from this particular psychologist in this particular setting, that it just doesn't count anywhere else or whatever it is, right? Like this comes up a lot. And so we had that, I just was parting it because we had the same discussion.
Yeah, and I put this in the chat, but like, do other states require both of these things? Or are we okay, so it's pretty common that you have I'm saying nods. So
Oh, I just want to say I'm nodding and like agreeing with your question, but I saw thumbs up. So I don't know what that means, but I agree that it would be interesting to look at what other states are, are doing. I
yeah,
think that's a really good question.
yeah.
My understanding is, I think school psychologists, they're trained differently. They're not the same as in their training as other psychologists. It's a master's level psychology degree, not a doctorate level psychology degree. I don't know that they have the training to diagnose. So it's a different level. But I think to the point, they do the assessments. And so I don't know why their assessment couldn't be part of, if you gave it to someone who then could do the diagnosis, they could at least use that as as informative to do a diagnostic in the way that you use other information to do a diagnosis. They don't have to start from scratch.
Mm-hmm. Okay, I'm going to move us on to the next topic. But before I do, I just also want to give a shout out to the Access Project at Ocean. This was kind of a new to me program that is not available in all counties, but in many counties, particularly rural counties. And I wonder if it's contributing to that reason why this isn't coming up as much for 0 to 5-year-olds. So Emily, I see you here. I don't know if there's anything else you want to add about access or ways that we might be able to leverage and possibly expand that program to older kids. I think there's some great opportunity there.
Yeah, I mean, it's just exciting to hear so many people talking about the need for EdMed collaboration. So that's great. Um, I will say that it is coming up a lot within our conversations with various access teams around the state, the need for the ability to diagnose older kids. And so I don't know that we have solutions, but I think we'd be happy to talk more about what's worked so far with access programs for 0 to 5 as well.
Great.
Tammy, I don't know if you have anything you want to add, but no. Okay.
All right. If you want to learn more about access, I dropped the chat and the link, and Emily is here. I'm sure she'd be happy to connect offline with you if you haven't heard about it before. But let's move us to care coordination. I think Anna was in that room and some folks from Medicaid division. Who's going to report out?
I can do it. So we had a lot of sort of system folks in that space. And we kind of talked about sort of two pathways. One is sort of really based on who it is that we're working with in terms of who's asking for care coordination. So if it was a family member or a youth themselves asking, we talked about some strategies that had worked, and we had a youth in the room who shared a strategy that worked for them, which was that their primary care provider, their doctor, referred them to a program called the Dovetail program and gave them some specific language to use, where they actually called that program and asked specifically for a behavioral health care manager. And then they were assigned a person who was really helpful to them and found all sorts of resources that they did not even know existed that this person was able to sort of unlock. So that was kind of, we talk a lot about like you have to find the code and then you have to find the right door and then you have to enter the code and the door in the right way. So that was this youth explaining how they had done that exact process. We talked a little bit about when a community-based organization is asking for it and who they might ask and how different systems may respond. And so, if it's an individual asking your CCO for a care coordinator specifically or a behavioral health care manager, right? Like using the codes that you need to use in order to, not the Medicaid codes, but like the secret words that you have to use to get the door to open in front of you. And if those things don't work, to call the OHA ombuds team, which is sort of always our like, call the ombuds, our cry. And for community-based organizations to reach out, maybe partnering with innovator agents, right? Really trying to figure out collaborative approaches to figuring out where is the gap here. And can we just facilitate a bridge over that gap, but through conversation and collaboration, or do we really have a resource need where there's something that doesn't exist? And then we had a success story from Trisha. I'm sorry, I don't know how to say your last name, DeGeros, from the Coos area, where they have a community partner staffing that starts on day one when a young person goes into the emergency room with a behavioral health care need, to try to really make sure those community-based resources are communicating whether that person is discharged that very day or whether they move into a higher level of care, that their community is really collaborating and communicating from day one, and that is only a few months old, but really feels like a promising solution that's happening down in the Coos area. So community who was in my room, if I missed any important updates, please add in, correct if I misspoke.
I have a question. Did anyone bring up the potential role of the certified community behavioral health clinic in providing care coordination? This is my hot topic of the month. But
we did not. We talked about the new care coordination rules. I think the sort of the question that we danced around the entire time, which I think who was it that said it? Emily from Ocean said, well, really the issue is who coordinates the care coordinators and how do they know how to hand off the work as the person moves through the system? So conversation was really focused on how our work centers the system instead of centering the family.
Mm-hmm.
But nothing about certified community behavioral health centers, Christy.
Okay. Yeah, I'm just this is a topic I'm particularly curious about because I look at the CCO care coordination rules and I look at the standards, the care coordination standards for the certified community behavioral health clinics, and it based on those two documents alone, it looks like the effective care coordination should be in place and working for kids. So something is not working there, and would love if anybody has a little bit more kind of ground level view of what is going askew there.
I can't speak to the community behavioral health clinics at all, but I can say from the short time I've been with OHA and looking at CCO care coordination, I think there are a couple big issues. One is that people don't know how to access care coordination with their CCO, or maybe how to express what they need from their care coordinator at the CCO. That's been a across the board trend that we've heard from many different partner agencies and systems. We don't know when to call, how to call, and then we don't know how to ask for people, how to ask for support. And then I think the other big issue that's coming up is what we're seeing across the board as well, right? We might have newer staff who don't necessarily know all the resources. They might be trying to navigate and coordinate for somebody who's really complex and they're not entirely sure where to go. But even if they do know where to send somebody for care, they might not be able to get in quickly. There might be wait lists, there might not be staffing. So I think we're just seeing these trends across the board. And we don't get a lot of complaints about the care coordination that people do receive. Like when I look at the complaint data for our CCO complaints and grievances, it's very low compared to our membership who's receiving care coordination. And so I really think a big piece to solve for is that front door and helping people to understand how and when to contact their CCO. Yeah, where do I start? Exactly.